for snoring. Usually we think that tonsillar level or velopharyngeal level. Something I got surprised to see the findings. So without doing DICE and MRI, we should not operate. That is my message to all. The first case was 26-year-old male, is very thin patient. On third patient also 22 unmarried female patient. Case 2 is a pilot from Malaysia. He had some breathing difficulty. So I thought of septum only the problem. I did the surgery. Then after that again the patient came. Then I evaluated all the findings. I did a polysomnography. I got the result around 20 to 45 range. We usually notice all the examination like this. Then step 2 we do some basic investigations, and step 3 only we will plan for higher investigations. What is our role in OSA from septal correction to the tracheostomy? Various surgeries are available for the OSA surgery, but my finding is very different. The first case I had like epiglottis collapse. You can see in the CT also. And second case, the pilot had elongated uvula and epiglottis collapse also. The elongated uvula due to the Bernoulli's phenomena. You can see the length of the uvula. Third case, that female, very thin individual, she had mass in the areobicular fold. I didn't accept this finding because the speech was very normal. I thought some sonoma, something like that. Then first case, I operate the partial epiglotectomy in tonsillectomy position and making an incision with the monopolar cautery. You can use any tools like a coagulation or a microdefibrillator. First thing, you have to excise the mucosa, then you have to remove the cartilage. This is the cartilage bed. That is half of the cartilage. So this is the incision we make, then immediate operative. I can see this. This is post-op picture. This is after a week. The patient does not have any complaint. Second case, that elongated wound also removed, and I did a partial epiglotectomy. This is our length of the uvula. Third case, this is the mass, very difficult to remove with our usual tools. Both the cards are normal. The patient had only choking sensation at the chest level. Then I took biopsy. I used all type of instrument in this case, radio frequency and the microdefibrillator. The biopsy came as a tuberculosis, surprise to take. This is post-op, immediate post-op. You can see the slip in the areobicular fold. Then after 3 months of TB treatment, I could see the normal. Sorry. Then second case, patient does not have any aspiration or any difficulty in breathing. Second patient, modified uvula is there. Patient doing the well. So definition of success according to everyone is, I got all very good result for these patients. So we have 3 different patients with a history of snoring, but without a typical feature like English PMA or English neck circumcision or palpita. All 3 patients underwent the complete evaluation with the dynamic studies. So while treating a patient with complaints of snoring, the multiple levels should be considered and should be ruled out with the different investigations such as MRI and DICE. Uncommon cause for such as TB also should be considered. patient who have low or normal PME with atypical presentation of supraglottic area. In case of epiglottic collapse, as we all know that efficacy of the CPAP is limited, contraindicated, so that will worsen the symptoms. So surgical management will be preferred. No patient complained like aspiration or anything like. All three patients are doing well without any symptoms. Thank you so much for listening.
Again, a good presentation by